My name is Peter Stanton, and I am the publisher of the Worcester Business Journal, and I'm very pleased to greet you this morning, and I'd like to thank you all for coming out to this, what we hope is going to be a very robust discussion and about the latest legislation in Massachusetts and how it's affecting our overall healthcare system, and certainly how that's having an effect on consumers and businesses. And we're very excited to have you here today, our keynote speaker, and a terrific panel. I'd like to start by thanking our sponsors, our presenting sponsor, Fallon Community Healthcare, and our media partner, WTAG Legal Ease. This event was put together really because there was a new state law, yet another new state law affecting healthcare that got passed this summer, and there's a bunch of details to that law that I think we're going to hear discussed over the next couple hours. But we wanted to provide a forum where the business community could come out and hear a robust conversation about that, how that's going to affect all of us, and how that's going to affect our local healthcare industry. So, without further ado, I want to bring up to the microphone for some sponsor welcome remarks, Pat Hughes, who's the president and the CEO of Fallon Community Health Plan, our presenting sponsor. Pat.
Thank you, Peter. Good morning. On behalf of Fallon Community Health Plan, welcome to today's Healthcare Forum. I'd also like to welcome Attorney General Martha Coakley, and our distinguished panelists who will be with us today, Senator Richard Moore, Dr. David Fairchild, Glen Shor, and John Hurst, and you'll hear more from them later in the morning. You know, it's hard to imagine now, but there was a time when health care and health insurance was one of those sleepy topics that nobody really talked about. Nobody really talked about other than those of us in the industry. But then times have changed. In 2006, we had massive legislation here in Massachusetts, health reform. In 2010, we had the PPACA legislation passed on a federal basis, and all of a sudden, the industry has exploded. The other concern and the other area that we need to address is obviously the rising cost of health care, the increased demand for care and services, and a very difficult economy has all lent itself to the kind of situation that we find ourselves in today. And what we need to do is find solutions to the problem. And I believe that that's what we're going to hear about this morning. Many of you have probably heard me say on more than one occasion that Fallon Community Health Plan has always worked extremely hard to be a part of the solution as opposed to a part of the problem. And we continue to do that. And while we're proud of the many innovations and all that we've accomplished over the last 35 years that we've been in business, we've also learned that being a part of the solution really relies on working with other constituencies, with legislators, with provider groups, with employers, with consumers, and with the brokerage community to try and find and develop solutions that are sustainable as it relates to price and quality. Last week we had the opportunity to bring together a pretty diverse group when we hosted our second annual Coordinated Care and Coverage Conference, which primarily focuses on the senior space, Medicare Advantage, our PACE program of all-inclusive care for the elderly, and so forth. But we were fortunate to hear Dr. Don Berwick speak, and we also had on that, at that day speaking was Tom Scully. So we had Tom, who ran CMS under Bush 41, and Dr. Berwick, who ran CMS under the Clinton administration. And it was interesting to note that the differences between these individuals were minimal at best, and they were all focused on the same things. We're proud to be a part of today's event and have the opportunity to work with the Worcester Business Journal and to bring this group together to listen, to talk and to learn about a topic that's critical to the business community here in central Massachusetts and throughout the state and the country, and is important for all of us to understand better. So welcome, and I look forward to a good, lively discussion. Thank you.
Thank you, Pat. Okay, it is my pleasure to do the introduction of our keynote speaker. From a Bostonian's perspective, a trip to Worcester is often considered a trip to Western Massachusetts. However, our keynote speaker does not share that erroneous worldview, not just because she's a regular visitor here to the central part of the state, but because she was born and raised in North Adams. And those who need a geography lesson, North Adams is in the upper left-hand corner out there, surrounded by the actual Berkshires, not the Seven Hills of Worcester. So Martha Coakley charted a career as a distinguished prosecutor on the state and federal levels before serving as a Middlesex County DA and then becoming the Commonwealth's first female Attorney General. Re-elected to her second term in 2010, Martha Coakley has devoted her career to protecting children and public safety, standing up for consumers and taxpayers, and fighting for equality for all the citizens of our state. She's had a myriad of successful corruption, fraud, and criminal cases, successfully challenged utility rate increases, and has recovered over $100 million in Medicare fraud cases. In reading her bio, one of the Attorney General's strong suits is her ability to forge innovative solutions. That skill was put to use in 2010 when her office issued a landmark report on the significant cost drivers of the healthcare system, a report that helped steer the debate on solutions to control costs for families and businesses, and certainly contributed to the state's newest landmark healthcare legislation aimed at controlling healthcare costs that was passed this past summer. We're fortunate to be in a state that is playing a leading role in the healthcare arena, and very pleased to have Attorney General Martha Coakley here with us this morning to share her thoughts and insights. Please welcome Martha Coakley.
Thank you for that warm introduction, and thank you, Pat, for welcoming us all here. I asked Jesse what these were for on the table, and he said in case anybody's falling asleep, you can throw them at each other. So I'm going to keep an eye out, too. I brought mine up here, so if the ball lands on your table. It seems to me it's my job in the next couple of minutes, A, to keep you awake, and B, give you a couple things to think about for the panel that's going to follow us. And I want to say I'm delighted to be here and have the opportunity not just to talk to you a little bit about what we've been doing and our perspective on this, but also to do question and answer. It's important for me to hear what's on your minds about this topic in particular, because this is a work in progress. I want to say I look forward to the comments of the panel, and particularly I want to tell you how lucky you are to have Senator Dick Moore as someone in the state who understands this. Dick? Who's been working on this for a long time and who is incredibly thoughtful about this topic, because as many of you probably know, it's a little bit more complicated than some of the things that we do and some of the things that the legislature does. But as a friend of mine who's a teacher said, a lecture is a long answer to a question nobody asked. And I don't see this as a lecture so much as a chance to start the discussion with you today that will continue with your panel, but also I hope with each other, with your legislator, with the governor, with us, private, not-for-profit sector, because this is an ongoing journey around healthcare that I think we've made progress on. I think we can continue to make progress on. And so I want to do three things this morning. First, I wanted to give you a little bit of history as to how and where we got to 2006, 2010 around healthcare. Secondly, I want to give you a quick assessment of, I think, where we are and what the current legislation is trying to do, and take a look at whether it can do it or not. And third, why should you care about this? Why is this important to you as a business owner, as a a family member, is somebody who presumably wants to be healthy. Why is it important to you, and what can you do about it? Because I think one of the biggest problems on a topic like healthcare or energy is that we all feel a little bit helpless, that it's not our area of expertise, and we feel a little bit at the mercy of so many other things going on around us. I don't think that has to be true, but I think that can be the perspective. And so part of today's discussion, I hope, will try to demystify some of what's happening in healthcare, as not to be confused with a healthcare delivery system, and try and think about it in the business terms that are so important for you, for your families, and for your companies. So I did grow up in North Adams. I was born in 1953. My dad had his own insurance agency out there. He started selling insurance out of Springfield after World War II. So we always took insurance for granted. We had very good coverage, and we were lucky in that respect. I remember that Dr. John Cashin used to come to our house with his brown bag. How many of you remember the time when doctors came to your houses? Show of hands. Don't be embarrassed. I know you're not all digital natives in here. You know, we were lucky because he knew the family history. If you had a sore throat or you had chicken pox or measles or mumps, he came with that brown bag, and inevitably you would either get aspirin or cough syrup, and it solved all the problems. Life was a lot simpler then. And Dr. Cashin actually took care of all of us, my mom and dad, until my mom came to Boston at the end of her life, but took care of all of us. But something funny happened along that way from the Ozzie and Harriet world that many of us grew up in. And some of it was good, but it's important to understand that that was a time before we had all of the diagnostic diagnostic tools and remedies that we have now. So along the way, we develop increased use of x-rays, we develop CAT scans, we develop MRIs, we develop chemotherapy, we develop a very sophisticated and yet important way that we start to diagnose and treat people who are sick, who aren't feeling well. And as we grew up in that system, some of the things that happened are we continued to take for granted that it would be paid for, that we would get what we needed in terms of diagnostic tools and treatment, but the costs of those kinds of things started to escalate. And the costs expanded and grew, but our expectations, of course, that they would just be paid for stayed the same. And I've often likened this to what happens at the open bar at the wedding, right? It's there. You may as well take advantage of it. No one tells you not to. And someone else is paying for it. So it's a good deal. And I use as an example of some of the things that I think are wrong with the system is my husband's foot. Now, my husband, Tom, is a new skier, and he got some new ski boots a few years ago. I think the boots were too tight, but I'm not sure what happened. He came home from a ski trip, and his foot was both numb and painful. So he went to his primary care, and she said, I don't know what's wrong with your foot, but I'm going to send you to this doctor. The doctor said, I don't know what's wrong with your foot, but let's do x-rays and take a lot of pictures of it. Nobody knew what was wrong with his foot. He finally, after going through physical therapy, got some relief from it. But along the way, there were a lot of things done to his foot that people were paid for doing. Nobody really owned the diagnosis of the foot, and it got better on its own ultimately. And it was one of those things that illustrated for me that nobody was really responsible for whether his foot was diagnosed properly or was taken care of properly, but it ended up okay, and people got paid along the way. So in a fee-for-service system, and this is not a criticism of anybody in the system, it's kind of the way it grew up, is that if you do a thing, you get paid for a thing. And so you can imagine, as you start to see the number of things we can do and get paid for in healthcare, x-rays, CAT scans, MRIs, to diagnose, with people somewhat on an assembly line of trying to figure out what's wrong and nobody really owning that problem, that you don't always get the outcomes you want, but more importantly, it's very expensive. And it's very expensive in a way that doesn't ensure the best result, the quality of care that you would like, and frankly, that we can continue to pay for a system like that. And so what happened, what is happening in Massachusetts, starting back in 2004, 2005, was the understanding that healthcare costs were just too high. They were at an unsustainable spiral up, 8 to 10% a year. Businesses were starting to complain. The government couldn't pay for it. None of us could pay for it. And so Massachusetts, as many of you know, took 2 steps to approaching this problem. Let's get everybody insured first. Let's get everybody in the pool. Remember that great old conservative idea of the individual mandate, that you would pay for this because we were all in a healthcare system. In fact, 98% of Americans are born in a hospital. We start out our lives using the healthcare system. Most of us use it or want to be able to use it. So the idea made sense. Let's make people pay for this if they can, and then we will have the pool, and then we will start to look at bringing down healthcare costs. And so that is the phase after we got everybody insured that we've started more recently, that we would get people insured and then we would attack costs, because we believed that that cost growth was unsustainable but not insurmountable. And that's where the hard work has come in, trying to look at what it is driving those costs and how we would start to bring them down. This past weekend, my husband and I had a chance to spend some time in Maine for the weekend, and it was the first time it became really clear to me what people in down East Maine mean when they say you can't get there from here. Because if you look at the Maine coast and you're on one corner and something that you can actually see, you can't even get there without going all the way around. Well, we realized that we can't get there in terms of cost savings from where we are. We could not, given the system we have, with a fee for service, with lack of transparency, with market dysfunction. We had to really deconstruct some of that. We're doing that now. We had to take it apart in order to get there from here. Well, where is there? I would suggest that there is the sweet spot in healthcare where we are paying for coverage and care that we need, not that we don't need, but that we need, that we know the difference between what we need and what we don't, and that we are able to pay for it. And so if we assume that getting there is a goal we all agree in, and I think Massachusetts is unique in having the collaboration between the private sector, the not-for-profit, with government. And this is unique, I know, because I talk to my fellow attorneys general across the country. We are unique in having that collaboration back in 04 and 05 about getting everybody covered and tackling costs. We are unique in continuing to have everybody at the table looking at how we can do this cost containment and how we start to bend that cost curve. And some of this has been understanding that it's not just one thing or another thing. It's not just passing legislation. There are a lot of things involved. And part of what trying to get there to that sweet spot involves are looking at, as we started to do, and as referenced in Bob's introduction of me, the idea that we needed a little more transparency on this market. So starting in 2008, we started to improve transparency, to pull back the curtain on what was really happening in this market. We had anecdotal information. We had a lot of sense of how the market really worked, but we didn't really have the data. And working under Chapter 305 back in 2008, we started to do what my folks call looking under the hood of this big car of big car of healthcare, not auto insurance, but healthcare and healthcare costs, because we had expanded authority to gather information and to start to look at that. So we published 2 analyses showing, among other things, the wide disparity in prices paid for hospital and physician services. In other words, you could go to Boston, and I'm making some of these numbers up, but you could get your knee done in one hospital for $2,000. Another hospital was $1,000, and yet there were disparities in those prices not explained by quality or other value-based factors. So our reports illuminated the role of market leverage. That is, who gets to charge what? Who gets to say what we will reimburse you for if your doctors or your hospital does this procedure? Who gets to say how much that should be and what is that based upon? We started to show that there were some dysfunction in the market because of differences in clout. After that first report, we worked with the legislature and business groups to help with the 2010 law, Chapter 288, that then gave consumers and businesses more options in purchasing health care by requiring health plans to offer at least one tiered or limited network product to encourage value-based purchasing decisions. In other words, we're starting to say, look, you all have to be engaged in this now. This is not just about a system that you buy a product, walk away, and assume you can pay for it. We need consumer engagement in this. We need it for those who are buying insurance for their companies or for their families. And we need it for those who are using healthcare. And so the engagement piece of everybody cannot be underestimated. Chapter 288 set further rules for the Division of Insurance for use in reviewing requests by health plans to increase small group premium rates. All of these are smaller details, and I know some of these details Glen and the other panel will get into as to how this works. But what I'm trying to do this morning is give you the big concepts about what we're trying to do and why you need to be engaged in this, and then so that when the Division of Insurance does something or the legislature proposes another change, you have some idea as to what is happening here. One of the good things that's happened is we've started to do these things, issue the report, bring some transparency to the market, start to look at ways we can bend that cost curve. We have seen a very positive response by the market, which I think is incredibly important. People who are in the healthcare industry, delivery of services, working on insurance coverage, you're always going to know the market better, frankly, than I will or Dick will. And we want you to be thinking along those lines in terms of what is best for the market and my place in the market in ways that agree with the goals that we have in Massachusetts to start to keep the quality of care, keep access while we start to bend that curve. And so if the market is responding to some of these changes, that's terrific, because then you will start to have a functional market with transparency, with competition, with consumer engagement that drives a healthy market, and it's an important key point. Now, easier said than done, and we all know that. So this is part of the getting to there. How do we get there in that sweet spot that we talked about earlier? So as we have looked at the most recently statewide healthcare cost growth and how we can bring that down, we know we're not there yet, but this most recent legislation, I think, takes into account the fact that the market has made some changes, maybe not fast enough, maybe not far enough, but that we, the legislature, the authority that we already have and some increased ability to monitor this market, will work with you on where the market is going with those goals in mind so that the market can continue to change and grow, we hope. That the government will be a partner in this, not in the way, but with that goal in mind of getting to where we need to go. And so as we move forward on that, why does that matter to you, and what do you need to do? I think, first of all, it is important, and I know that there's a lot of overreaction to the state is nanny state, and you know, I understand that we think we have a constitutional right to have a 32-ounce big gulp. You know, there's an incredible reaction every time someone says we're going to regulate, and I appreciate that. I just think it's the wrong argument. I mean, we really don't want to spend a lot of time testing our constitutional right to drink, you know, sugary, caloric-filled drinks. If people want to do that, they're going to find a way to do it. But I think everybody has an interest in knowing what's in that Big Mac you're eating. What are the kinds of things that we are doing? You have an interest and you have the ability to start to take control and be engaged in what is a really important piece that doesn't get talked about enough in terms of healthcare costs. Doctors will tell you this. Doctors understand the importance of prevention, of your own engagement in staying well, right? Just as we maintain our cars until there's something wrong and we take them into the shop, we should be maintaining ourselves and our systems as well as we can until we get sick. We've lost a little bit of that in a system where we have so much available to us that we think we are on autopilot. We can do whatever we want, and if there's something wrong with us, a doctor will fix it and someone will pay for it. We've got to change that. Two big cost drivers, for example, are diabetes and asthma. Both of which, if we could do better education and prevention about, would bring the cost curve down on treating those, never mind the cost we pay for children who suffer from asthma or from early onset diabetes. Important things that we need to engage people, again, in the level of prevention, primary prevention, and health literacy, understanding what this is about. The second thing is engaging you and your companies at the level which you purchase coverage with the range of options that make sense. This is the idea of giving you more transparency about the market, giving you tiered products, letting you buy the kinds of insurance products, coverage, that you need to cover statistically what you're probably going to have to deal with. Now, the thing that people worry about, the thing we don't talk about, is what does happen if my child gets leukemia? What happens for the unexpected, not just the regular health maintenance that we know we're going to have to pay for, but what happens for the catastrophe and disasters? That's where the system needs to provide for both the reinsurance for those catastrophic events, as well as the peace of mind that you will have that, instead of we all worrying about all the time that we're covered for everything all the time and we'll never have to pay for anything. We have to have significant discussions about what it means to buy the coverage we're buying and what it covers and what it doesn't. And the third piece is individuals need to become engaged, I think, in the discussion with their professional partners, their doctors, their nurses, the midwife, the social worker, all of the teams that are now developing around preventing problems but keeping people well when they get sick, getting them better, and dealing with end-of-life choices, whatever that may be, so that we make those professional judgments that are best for us. That we're not at the mercy of an assembly line system that says, well, go get this test and go have this test and go to Boston, that we get engaged in what that is about, that we get involved in planning that. You know, back in the early 90s, my dad was playing golf out at Taconic Park. He had played 18 holes of golf. He sunk his last putt, and he died of a massive coronary on the 18th hole. As shocking as that was for all of us, 18 months later, when my mom died of leukemia, I said, I'll take the heart attack on the golf course. When she was diagnosed with leukemia, we did bring her down to Boston. And she did go through a series of protocols and chemotherapies that were painful. They were difficult for her. And I think in retrospect, not suggesting anybody did anything wrong, we had no idea what our options were. We hadn't thought about it. We hadn't talked about it with my mother. I would do that differently now, and I think she would too. And I think that's part of what we all need to do in becoming engaged in what this means with the diagnostic tools and the remedies we have available to us. And what does it mean to have control as individual consumers on that? Because then we will start to get the results we want. Engage consumers, demand for transparency, demand for the kinds of products and healthcare that we want. So I do think we can get there from here, but it's not simple or quick. And it needs everybody at the table to do that. It needs you to get engaged. We in the Attorney General's office are going to continue to look under the hood. We're going to continue to work with all of our partners on this incredibly important goal to keep us insured. We cannot underestimate the role of primary care physicians, of nurses, of the kinds of folks that we need to make sure we get the best care at the cost we can afford. But we are all responsible to try and make this work. Not only is it important for us, everybody in the country is looking at what we do. I'm proud to be the Attorney General from Massachusetts in so many areas because we have great partners, whether we're trying to keep people in their homes for mortgage crises, we're trying to keep healthcare costs down, we're trying to provide for a system that will let people use it to their maximum ability. And so with that, I'm happy to take questions or comments and appreciate that you're all here this morning. I didn't have to throw my green ball at anybody, as far as I can tell. There's always a 7-second delay till the first question. Yes?
I'm just thinking that if the Attorney General of Massachusetts would do things differently if her mother had terminal leukemia today, isn't transparency a red herring?
I'm not sure I understand the question.
You are certainly a consummate consumer in this room. It just seems to me that if you made a statement like that, I had a mother who died in the same kind of way, and I would have made the same
Well, no, and that's a very fair question, and I think these are always the tough questions, right? So we often avoid these discussions. Look, this is 20 years ago, and my mother was 72. She is diagnosed with leukemia. Obviously, the diagnosis and some of the treatment that are available now were different then. We brought her to Boston, and we were basically told, you know, look, we can do these protocol, and we think there's a chance that she'll survive. I mean, that's what we were told, and that's what my mother told. We wanted to support her decision-making, obviously. I'm not talking about us deciding, but her decision. And she said, okay. And then in retrospect, as we went through it, it seems to me, and I know a lot more about this now, I actually got involved at the board of the Cancer Center in Boston, so I could understand more about this, what it was for consumers to have the right information to make those choices. My mother said, you know, before she died, if I'd known what this was going to be like, I might have done what Jackie Kennedy did, which was choose hospice care and then, you know, die at home. And that's the kind of choice I'm talking about, that for many of us, including me, we grew up thinking doctors know everything. And when they say you should do this, we would do it. We're a good Catholic family. We, you know, we trust authority. And so we didn't really think much about doing anything other than putting her through those protocols. She didn't either. And I guess that's my only point. It's not to be critical of the doctors at the time or the hospitals. They were doing what they felt was in their best interest of the patient. But they don't always know. And I know this from the criminal justice system. I've learned that through many years of working with victims of crime, victims of human trafficking, victims of domestic violence. I don't know what they think or what's always in their best interest, but I do know that we try and give them an ear, that we give them options, that we give them choices. And when I talk about choices, I think it includes that whole range of what kind of insurance product do we buy in the front end, and what choices do I have when I get a diagnosis like leukemia at age 72 or at age 50? Those choices are going to be different. You know, she was too old at the time for a bone marrow transplant. We understood that. But the push to do protocols is something we might have reevaluated if we had thought differently about it. And I guess I'm being as critical as us for saying we grew up at a time, Dr. Cashin comes with the bag, he tells you what to do, you take the aspirin and everything will be okay. That has changed. People have choices, they have options, we all live longer, we can prolong life in many ways. And these discussions about what people want, not about death panels deciding for you, but what about educated consumers who start to say, I am responsible for, you know, controlling my diabetes. I am responsible for making sure that if I can, my kids don't have environmental factors that cause asthma. I am responsible at age 72 or 90 in determining how I want to die. I mean, these are legitimate questions for people to make in with their doctors, with their families, and I just think my generation, at least certainly my parents, didn't do that. So if I'm missing the point of your question, I'm happy to have follow-up from you. Yes.
You touched upon it a little bit, but I'm a provider. And one of our frustrating things is patient compliance. The idea that you tell a patient, here's what you need to do, the patient doesn't do it, and now we're being held responsible for that. How are we going to deal with that in the new world, where a patient doesn't really want to do it? They come, they get their fix, but there's no maintenance to that fix.
Well, that's a very fair question. As you're asking that, of course, I deal with that as a lawyer all the time. When you take the stand, please say this, you know, or answer truthfully, and then your client goes off and does something completely differently and then comes back and blames you because you lost the case. You know, we all deal with that. In some of what I'm suggesting, I think we do have a patient population, I think, that has that Ozzie and Harriet, Dr. Cashin mode that, look, you can tell me what to do, but you're responsible for keeping me well. I don't care that I don't change the oil in my car. My car's not working, so you have to fix it. And by the way, you're going to pay for it. And if you screw it up, perhaps we sue. Yeah, no, I totally understand that. I think that is part of what we deal with in a way that says, how do we change that dynamic? How do we engage people to be more responsible for their own care to begin with, their choices, and understanding that doctors, as wonderful as they are not miracle workers. That if I give you advice and tell you you have to, take this medication or you have to start walking more and you don't do it, you can't expect that you won't have the same health care problems. I mean, part of what we're talking about as we engage is looking at more of dealing with there are reasons that patient doesn't do it. For instance, you are very rational and you say as a provider, take this. You can't imagine that somebody wouldn't do it. But the emotional, stressful kinds of things that people do when they are sick and their failure to follow directions come from different places, which is why a lot of places are looking at the way we do teams around healthcare prevention, getting people well. A lot of individuals and families really need more of a social model, a social worker care model that says, why is that patient? That's not your job to figure out why the patient isn't compliant. You can't, that's beyond the scope, but somebody might want to do that. And it may be the person's just stubborn and doesn't really care. Maybe there's other things going on. Why do children not use their inhalers when they should? I mean, there's lots of reasons that come into looking at exactly what you've raised, but that's a legitimate question. If that is a driver of cost care and it's a problem that doctors and providers want to solve, we need to ask that question and figure out, is it an outlier? We can't worry about it because it's statistically, or is it a mainstream problem? And I think the more we start to realize that healthcare and how people deal with the decision making is so emotional, for the prior question, what do we do to diffuse that and give people some help around making the right decisions? But certainly, I don't disagree that you should be able to limit your liability if you give people good advice and they don't take it, and then they come back and complain. Yes?
I'm curious to know what role your office will play in helping consumers shift their mindset. The medical imperative has become hardwired, virtually, as an entitlement in consumers' minds. And it seems to me that that runs it right through the Attorney General's office. So I'm curious to know what role you see your office playing in helping consumers to develop that shift. Because if we continue to function as, for consumers, that healthcare is as an entitlement in terms of the medical imperative piece, we won't achieve the objectives of healthcare reform.
No, you're exactly right. I think that's exactly right. And so I'm just looking through my notes because there are a lot of specific things that I think, and perhaps people on the panel may address them also, but improving price transparencies for healthcare consumers, and letting people know, for instance, one of the things that I know we've been on top of is trying to make sure that consumers get timely, reliable price and plan information about a plan, procedure, or service, whether it's covered, what the price is, what the copay is when you come in. We have established a toll-free number, a website, so that people can not only know that information is there, but actually get it and use it. And this is a mindset change. This is really changing the lens on how people think about what their role is in the healthcare system. And I think that's exactly right. We can pass legislation and make these tools available to people, but unless they are engaged, unless they know there's something in it for them and they need to do it, you'll get some resistance to it. Look, people's lives are busy and complicated, and we have to make it as easy as possible. But like any market, it will function if people who are in it understand what they need to do to make it work for them, and that's a part of it. And I say that saying I think many people in the room probably have better answers than I do about how we start to do that. That's why this collaboration around this process is so important, because we can pass a statute, we can say to healthcare providers, you have to put this information up, but how do we actually get consumers to do that? What is the mindset, or what are the incentives that we have to provide for people to do that? So it's a fair question, and I think that's part of the getting to there that we have to keep talking about. Yes?
Hi. My name is Janie Kelly, and thank you for being here. In reference to your conversation about transparency, people becoming more engaged with their own decision-making process by perhaps being included within a team of physicians, social workers. I know myself, when I'm going to take charge of my own health care and ask questions, one of the things that concerns me is that whoever it is that you're asking, whether it be the insurance company, the doctors, who do they work for and what's in it for them in their answer to me? Whether it is a fiscal or a financial advantage to them to answer a question in a specific way. We have a level of trust, I think, in this country having to do with where it is that we're getting the information and is it really the truth? And then when you want to go get other information or another opinion about what it is that you've just heard, you're restricted. Your insurance company, you know, they want it this way. This is where I think, I mean, this is the first thing I heard you say that said, all right, there's a toll-free number that if you wanted to get an objective answer to a question, you know, you are deer-headed with a diagnosis, whether it be loved one yourself, and now you want to take care and command your own health care, you know, getting the right answers. But who do you go to? That's the big question, to know that you're really getting an honest answer. And there isn't a financial advantage to that person in that insurance company saying, you need to go, this is the right way. This is what you do, because they're trying to be cost effective. They're trying to keep your business. So you don't really, you know, emotionally, you know, it's a hard balance to, you know, get to where the truth is. And so when you say social agenda or social workers or people who aren't quite as involved because of the financial advantage that they may have, I think that's a better way to have people start taking better care of themselves. When I listen to, you know, 30 years social work background, a little bit of nursing, you know, who do you call? Who's really telling you the truth? You know, so their lives.
Well, but you're exactly right, and this is why it is complicated, and it means getting people engaged from an early stage and saying it's like any other problem, right? I have a legal problem. I may get two different advices on how to handle this case in court or how to handle my will. You know, we all rely on experts who have some sort of fiduciary duty with us, doctors, and take a Hippocratic oath. Lawyers have a fiduciary. But none of us are perfect in doing it. And because the system has grown up the way it has, it's harder and harder for people on this end to know because, again, through no fault of the people engaged in the system, you are somebody who's come to them for a particular problem. Their job is to look at your foot, and if they know, they maybe can figure out what's wrong with your foot or not, and maybe they tell you to do something and you don't do it. So you raise the problem for which I don't have an answer, except we've got to do better than we're doing. No one ever has a crystal ball on this, and it is true in other areas of our lives also that we have to develop that trust with people.
With healthcare reform, everyone needs a primary care physician. We definitely have a shortage, and the major problem is that a lot of folks in medical school want to choose a specialty, and they don't want to go into primary care. What at the state level are you looking at, or at the federal level, to incentivize physicians to go into primary care? Because they're definitely the key accountable person.
Excellent question. And I don't have a good answer for you. I will tell you that you've keyed in on something that another problem that has happened in this system as we've grown up with this era of specialization and fee-for-service. It doesn't take a rocket scientist to figure out that, gee, if I can go do plastic surgery or just do knee replacement, I'm not going to get called at 3 a.m. for those tough deliveries. I'm not going to be on call all the time. We've provided incentives financially and otherwise, I think, for doctors to do that. Meanwhile, the need for primary is huge, and I think that that is also something that we need to address with medical schools. And I don't know how much authority we have at the state level. We have some to start to provide incentives to develop that, because that is a linchpin piece to making this work. Having people come into a system initially through a primary and presumably a team that can do the prevention, do the diagnosis, do the treatment, unless then you have to go to a cancer center or you have to go have surgery someplace else. And so that's why this piece is so important. Recently ran into a doctor, retired, who said, you know, in the 70s, Congress had an opportunity to provide different incentives to medical schools to get more primary care physicians. They didn't take it. I think that there are some options, probably more at the federal than state level, but it is a question that has to be answered to provide incentives for that. Otherwise, this isn't going to work in the long run. And one more? Sure, yeah.
Earlier you were talking about the difference of quality of care compared to cost, and you were saying, I'm not sure of the real numbers. I'll give you one quick example and ask you a question. A brain PET scan at Mass General, $15,000. A mile and a half down the street at Longwood Imaging, it's $5,000. All right. There's a huge disparity. Now, you talk about people taking charge of their own health care and being aware of this quality and cost and being willing to choose a lower network, limited network. Is there any way that people can access published information that says, if my child has a problem, I'm going to Mass Children's Hospital. You know, don't tell me I have to be in a network that doesn't have Children's Hospital. If there was some published information that could say XYZ other hospitals have a quality to cost outcome that's equal to in whatever particular area this parent has a concern, that would go a long way to helping consumers accept this whole process.
Exactly.
And what are we doing about that? To me, that's transparency.
Well, you've hit it on the head, and that is exactly what our first reports and our subsequent reports are pointing out. Now, you could say in that price differential that the institution that charges $15,000 will come back and say, this is worth it. This is why we charge $15,000. To date, they haven't been able to do that, and that's where we've been critical about that charging. But that's where it's not just the ultimate consumer involved in that. That is about why did they get $15,000 for that, and what is the bargaining clout with the health care, with the insurance company or the provider that lets them get that reimbursement. So our work around showing those price disparities and starting to say to the market, there is an unwarranted price variation here that you can't justify. If you can't, and we don't see those things coming down, then we may, we always have more leverage sometimes before we do something than after we do something. We may want to step in and do it. We're in the process of that now, in that kind of transparency. But you're exactly right that until and unless we can demystify that, if I go to A, I'll get better care than if I go to B, because that has grown up around the branding of some of these institutions. I understand that. We're not being critical of it so much as we're saying it needs to change. And so our efforts in our office with the legislature, and frankly with all of you, saying this has to change or we won't be able to accomplish to get there, is what's important, and we're on that piece. So those prices should not be charged. There shouldn't be that kind of differential if there isn't value involved in it. So, thank you very much, everybody. Good luck.
So as part of her visit to Worcester, we'd like to give Attorney General Martha Coakley a Worcester City on the Rise book, a nice photo book of the region. No shots of the Berkshires, all of Central Mass. Please enjoy it.
Thank you very much.
Thank you. Terrific. So, straight on to the panel discussion, and I would like to bring up our moderator, who is Patrick Hughes from Fallon Community Health Plan. Patrick.
I'd like to invite the panel up if they would at this time. So now comes the part of the panel where, part of the morning where we have the panel to join in the discussion and kind of round out some of the issues and concerns and areas that the Attorney General had pointed out also. Our first panelist is Senator Richard Moore, who is presently serving his 8th term representing the Worcester-Norfolk districts. Senator Moore is the Senate Chairman of the Joint Committee of Healthcare Financing and one of the principal architects of the state's healthcare reform law. He also has been instrumental in crafting and passing legislation to improve the healthcare quality and to contain costs, and in the payment reform legislation, which we are gathered here today to discuss. So welcome, Senator Moore. John Hurst. John is the president of the Retailers Association of Massachusetts, a 3,500 member-wide, statewide trade association. John is also chairman of the board of the Massachusetts Retail Merchants Workers' Compensation Group and heads the Retail Association of Massachusetts Health Insurance Cooperative, which is the first nonprofit small business health insurance cooperative authorized earlier this year by the Commonwealth. Welcome, John. Our third panelist is Dr. David Fairchild. Dr. Fairchild is Senior Vice President for Clinical Integration at UMass Memorial and UMass Medicine at UMass, excuse me, I'll try this again. Dr. Fairchild is Senior Vice President for Clinical Integration at UMass Memorial Healthcare and a Professor of Medicine at UMass Medical School. Dr. Fairchild, who has been practicing internal medicine for more than 20 years, is also a health services researcher with an interest in quality improvement in ambulatory care settings. Welcome, Dr. Fairchild. And our fourth panelist is Glen Shor. Glen is the Executive Director of the Massachusetts Health Insurance Connector Authority. He oversees the program policies, operations, and staff of the Commonwealth Insurance Exchange, which has become a model of exchanges nationwide under the federal health care reform legislation. Prior to being appointed Executive Director, Glen was a leading policy point person for Governor Deval Patrick in implementing healthcare reform in Massachusetts, and more recently has helped fashion some of the recommendations that were incorporated into the payment reform legislation. So let's start the questioning off with Glen. Glen, pretend it's 2014. What does the connector look like? Who's shopping there? What kind of products are they buying? What kind of plan designs are they looking for? And how is the connector interacting with them?
Great. Can everybody hear me?
Yep.
I couldn't tell whether this was on. First of all, I wanted to thank the Worcester Business Journal and Fallon Community Health Plan for having me here today. It's great to be in Worcester. Worcester has a very special place in my heart. It's the town where my wife was born and grew up, the town in which my in-laws have lived throughout their lives and still live, the town in which I got married. So if you detect a hint of a New York accent, if I talk too quickly and can't squash it before it comes out, take it easy on me. I also, it's a real privilege to be up here and be at the same event with Senator Moore and the Attorney General, both who have played just an enormous role in the success of the Health Connector. Chairman Moore played a leading role in crafting Chapter 58, which of course established the Health Connector and has been a source of wise counsel and support throughout our existence, guiding us to be a good collaborative health insurance exchange that has been, among other things, a gateway for a lot of the formerly uninsured in Massachusetts to enter the ranks of the insured. The Attorney General, Martha Coakley, has just also been a key player in the success of the Health Connector. She actually appoints 3 members of the Health Connector's board who have been real leaders and stewards of health reform in Massachusetts through their participation on our board. And the Attorney General also played publicly and in Supreme Court litigation a really important role in defending the constitutionality of health reform in Massachusetts. So we really appreciate that, and we appreciate our continuing partnership with her and her superb staff. It's just a real privilege to work with her on these issues. You know, when I look forward to 2014, and I do look forward to 2014, notwithstanding I'll be another year older, I see a Health Connector that will be an even more powerful tool for small employers and for individuals who are shopping on their own for coverage for themselves and their families to access and find the coverage they need, to get access to federal and state programs that make it easier for people and small employers to afford health insurance, and also to secure access to tools to help them promote wellness, which we all agree is an important component of containing costs and strengthening the fabric of our families and our workplaces. I see a Health Connector in 2014 where our shelf is stocked with market-leading products. We've already begun the process of augmenting our Health Connector product shelf through our unsubsidized Commonwealth Choice program. Starting in January, you'll see new products from Fallon Community Health Plan, see new products from Harvard Pilgrim Healthcare, you'll see new products from Neighborhood Health Plan and some others. And that process is only just beginning. As I look forward to 2014, I suspect we'll have even more market-leading products, and they'll not only be the products that you see as popular and appealing in the market today. You'll see innovations in benefit design and programs that I think will serve small employers and individuals very well. You'll start to see carriers offering products with new types of networks, narrower networks, tiered networks, designed to provide adequate access to coverage while keeping the price of coverage affordable. You'll probably see new health insurance carriers. You might have read a couple of weeks ago that the federal government is supporting new insurance cooperatives, and there's one forming in Massachusetts. We expect them to participate in our health insurance programs, and we expect potentially other new carriers to be on the shelf as well. We expect to see new models for health insurance, ones where it's not just that the employer has the option of selecting one form of coverage and one form of carrier for all their employees, but models of coverage whereby employers may give employees a starting point for the decision, but give their employees a little bit more flexibility to customize health insurance, to select a carrier in particular that best meets their needs. We believe and are committed to offering this range of market-leading, innovative products on a shopping platform that, of course, offers adequate choice, but makes that choice comprehensible and simple for shoppers so they could understand what they're getting. That's really been a hallmark of our efforts to date. And with federal investments in our website, we intend to make it an even better, clearer, simpler shopping experience. The Health Connector will be a place where small employers can shop for coverage and continue to access new tax credits that took effect in 2011 or 2010 with the enactment of the Affordable Care Act, and also have access to tools to promote wellness for their employees and some real financial incentives for them to experiment with wellness programs. And we hope and believe and will continue working on ensuring that this process of getting coverage to the Health Connector is built on a couple of important foundations. One is we want to make sure that people can get in the door in a streamlined, efficient way. One real change that you'll see from the Health Connector in 2014 is right now, if you're applying for subsidized health insurance, it may take a long wait before we can figure out whether or not you're eligible and then get you into a program if you are eligible. We are building a major data pipeline with the federal government. This is a requirement of the Affordable Care Act that will allow us, for people who are qualified for subsidies, to assess their eligibility instantly and get them into the shopping experience with those subsidies so that they can choose the coverage they need with no delays. We really want the whole connector experience to be built on a foundation of collaboration with carriers and brokers. We'd like our shopping experience to be a tool that brokers can use to serve their clients even more efficiently and continue to do the great work they do on behalf of small employers. If we can assist that effort, that's great. Structuring the Health Connector's shopping experience, the products on its shelf, is not something that we just impose top-down. It is the product of a conversation with our health insurance carriers. We want them to see the Health Connector as a great shelf to sell their products. We want to hear their views on what they think can move the market in a positive direction, and we're really committed to working with them on these issues.
Great, thank you. Senator Moore, and let me, one editorial note, Senator Moore does have to leave us at 10:15, so we'll work him over between now and then. Senator Moore, the payment and reform legislation is expected to save approximately $200 billion over the next 15 years. How will that be achieved? Who will actually benefit from those savings? The state, employers, consumers? you
Well,
will.
thank you, Pat. And let me tell you that I did get a tweet from the executive offices of Fallon, and they've asked if all of the executives would stay here longer, and they'll get a lot more work done back at the office. So,
Well, we do have a few people in the audience.
so hang around. Actually, it will occur in a number of ways, and all of us hopefully are going to be the beneficiaries of it. Anyone who pays for health care certainly will experience some much slower growth in the cost of health care as we move forward, and hopefully better quality of care as well. The law covers a number of things. One is it sets a cost growth goal to try to bring health care, which is about double the cost of inflation, into line with inflation as far as it's determined at the state level. And we do that not by being overly regulatory. We do it by measuring who's going toward that goal, and then those who are not or not achieving it fast enough are going to be asked to come up with a plan to do it. We want the market to try to be the deciding factor in that, and each of the providers and the payers and others who are involved in the process and who know their businesses the best and who know how to get there to come up with those plans, rather than us say there's a one-size-fits-all scenario that folks would have to live by, and that would involve some folks that are just not going to be able to do it in the way or in the time that we'd like to see. It will be done in ways that certainly, as we make those reductions, there's a thing that certainly the insurance folks understand called medical loss ratio, which is that the percentage of your premium that actually is spent on your health care. And that has to be a fairly high level, higher actually than the federal standard. Federal standard, assuming it stays in place over the next several years, is that 85% of that premium has to go to medical purposes. We're at actually 90%. We will even off at 88 after a couple of years and stay there, so that that money that's being paid in premium, if you are not paying it for health care costs, actually goes back to whoever's paying, whether it's the businesses or the individuals or a combination of both. And we've actually seen that in play between both the state law and the federal law this last year, where several companies that weren't able to get to that percentage that they needed to be at actually had to go, I think it was about $41 million in rebates to businesses and individuals who had paid into the system but didn't get their dollar value, basically, as determined by the statute. The law sets up a variety, and we don't have the time to go into all of the details today, but a variety of mechanisms to help the providers to get to the level they need in order to get the cost down. We have, with I think a historic agreement between the medical society and the trial bar, have come together on some important changes in medical malpractice that we hope and expect will reduce some of the defensive medicine that gets practiced that does drive up the cost of care. We do, as the Attorney General talked about, do a lot more in transparency to help educate consumers on both where they can get good quality care at the most reasonable cost and how they can also work themselves to stay healthy. We create a lot of tax incentives and other mechanisms to help small business and business generally to promote wellness in their business, and it won't be just a check the box, I've got a wellness program. We're going to want to make sure that it's one that employees participate in and that we see health outcomes that are more favorable. So there's a lot of that goes on, but one of the things, the difference probably between Chapter 224 that we passed this year and Chapter 58 that we passed 6 years ago is that under federal law, we could only expand and extend our reach in the health care market to about half of the population, because about half of the workers are covered by self-insured arrangements. This will actually affect all people because it affects the overall cost, whether you are self-insured or insured by one of the commercial plans, that we will be pushing down the cost and making sure that the savings gets passed on to those who are paying, as well as to make sure that the quality measures are there and that we can monitor that And through the good work of the Attorney General over the last couple of years, we've seen that a lot of that information is available, can be made available, and it will be available to the consumer as well as to the businesses that pay the bill.
Thank you. John, since the Commonwealth's landmark healthcare for reform legislation in 2006, there's been additional legislation directed at the cost of care, and the vast majority of that has been in response to the challenges within the small group marketplace where your focus is. Are we on the path to fix the problem, or do you see any need for additional steps to be taken at this time?
Well, thank you, Pat. And just let me say, it's great to be here this morning. It's been good to work with Pat and his team over the last year with our cooperative, which is one of the things I'll talk about in a little while. But it's good to be here, and thank you to the Worcester Business Journal, and thank you for hosting it here at a member of ours here. This is a member of the Retailers Association.
That's a shameless political commercial that you're doing.
I don't think that was planned, but it was very welcome.
We'll take applications at the door.
Yeah. Look, it's no secret that there have been disproportionate impacts upon small business and their employees on the cost of health care, particularly in the years following the passage of Chapter 58. Now, I don't believe that was really a result of Chapter 58, but the double-digit increases that we saw certainly occurred for small businesses and their employees, and it didn't happen for those insured by government, big government, or big business. And the reality of that really brought some great reforms. We saw some great small group reforms in 2010, part of which had the ability to created the cooperatives and a lot of other small group reforms. And here again in 2012, the payment reform, really landmark legislation that I think will help us all. But making sure that small businesses and their employees really have a level playing field, it is very important, because you think about it, okay, the law says both on the state level and on the federal level that everyone must buy health insurance. And if indeed we're going to continue to have that, we can politically support that, economically support that, legally support that. Everyone should have the same abilities, same choices, and relatively similar costs. That isn't something that can be sustainable over the long haul if, frankly, your options and your costs vary quite a bit depending upon if you work for a big employer versus a small employer. And that really has been our focus. It has been in the two reforms of the last two sessions. And it will be something that we'll be watching going forward as payment reform and the ACA is implemented. I think along those lines, Pat, there are three areas that we're going to be watching going forward, particularly for our members and small businesses. The small business regulatory requirements under the ACA and how that intersects with Chapter 58. Senator Moore was a champion on reforming and fixing the fair share requirement here in Massachusetts. That was disproportionately hurting a lot of small businesses. It may need, and that was an important reform that just passed this summer. We're going to have to continue to watch that and how it will intersect with the ACA going forward. And we want to make sure our small businesses are no worse off than those in the other 49 states. We're also going to want to watch, we've known for a long time that, frankly, perhaps Medicare underpays, providers, and does that indeed, maybe have an impact upon the commercial marketplace? And going forward, the government payers are going to be very, very important, whether it's Medicare, Medicaid, the exchanges. They're going to have a lot of ability to contain costs for certainly their clientele. The question is, will that power, will that hammer, in effect, really translate into all consumers as well? And will those that buy on the commercial marketplace, particularly the small group merge type of marketplace, will ultimately what we pay our providers, be comparable to what government is paying? And then the third issue that we really have to watch is the issue of mandates and assessments. Look, I think all of us can agree, I certainly can agree that if I go in and use, go in and you go and get the good services of David's facility, and I should have coverage to cover those procedures. The question is, and that was the whole idea behind the ACA and Chapter 58, everyone should have the responsibility of covering their costs and making sure the rest of us don't pick it up. But I do see a disturbing trend. Since the passage of Chapter 58, we've had no fewer than 8 new state mandates passed, 8 new mandates and/or assessments. That is something that we've got to watch. These come under pressure from specialty providers. If you put something new under your requirement for health insurance, it's like Christmas every day for them. I mean, it increases their traffic or utilization. It also releases some of their ability, some of the economic ability to try to control costs. So that's something to watch. Hey, I'm a motorcycle rider. I pay extra on my auto insurance for the right to ride a motorcycle, and I think I should pay extra for that. I'm not sure anyone else should pay for that decision on my part, but I'm not sure I want to pay for other mandates for procedures that I don't want, will never use, and can't afford. In vitro is a mandate here in Massachusetts. I think we can all agree there are some things that everyone should have to pay for, but we've got to have a serious discussion going forward on if we want to retain this economically, politically, and legally, this requirement that we all buy health insurance, what is really required? Because if we keep pushing the envelope on that and require everything under the sun, frankly, it becomes looking a little less like health insurance and more like a tax, because gone is the basic assumption that you're supposed to cover your costs, and now we're talking about you covering someone else's costs. So that is something that we as consumers, we as small businesses, and we as policymakers have to look at very closely. And it does intersect with the ACA, because the essential benefit package, under the ACA really punted to the states, which is a good thing for low-cost states, not necessarily a good thing for expensive states and high mandate states like Massachusetts to give relief to small businesses and consumers. These mandates, it's popular to say they're a mandate on an insurer, but really the insurer just collects more premium. They really are a mandate on the consumer.
Thank you. Dr. Fairchild, the payment models are changing, and the pressure continues to increase to keep growth in the total spend of medical care down. We're indexing to gross state product here in Massachusetts. The number that is being bandied about is about 3.6%. What are the key things that providers, hospitals, physician groups need to do and do differently in order to begin to manage total medical expense down?
Thanks, Pat. Can everybody hear me? No? All right, I'll speak up, or I'll have the microphone turned up. It's a pleasure to be here, and thank you, Pat, for inviting me to be on the panel. As the provider on the panel, I feel that I and my fellow colleague physicians and our health systems are under the spotlight in terms of what needs to be done, because in the end, the rubber meets the road at the provider level, and it's what makes my job incredibly exciting. I have just come to Worcester about 1.5 years ago, and have practiced internal medicine as a primary care physician on the Navajo reservation out in the western part of the United States for a few years, and then have practiced in some of the big systems in Boston. But I will say that my move here to the UMass Memorial Healthcare System has given me the opportunity to probably have the most exciting job of my career, because of the opportunities that are here, partly, frankly, as a result of the sense of collaboration that I feel amongst the people here in the city, both people who are employers in the city, and then Pat and his group at Fallon Community Health Plan, just the level of collaboration that we feel. And then also, frankly, among the provider groups, as much as there's competition between provider groups, there's a fair amount of, we're in this together, and we have to figure out how to collaborate while we compete for business. So it's a very exciting opportunity, and it's, I have to say, I think I have the most exciting job of anybody at UMass. But in terms of the question, so it's a great question. What do we need to do at the doctor office level, at the hospital level, to get us down to the gross state product or below? How do we bend that cost curve? And one of the things that I think is probably the most fundamental way in which we need to change our thinking is that we need to stop thinking about providing health care, MRIs and CAT scans and office visits and hospitalizations, but we need to think about how to provide health. And this is not an idea that I came up with. People have been talking about this, but it's a paradigm shift, and it's very fundamental because you think about it, we are a healthcare system that's set up to provide emergency room visits or hospitalizations or scans. That's what we do best. But we don't really have the infrastructure in place to provide health at the most fundamental way. If health means how do I keep you healthy and at home and out of my office and out of my hospital. And so to really do that, because that's what this healthcare legislation change is really all about, is how do we keep our population healthy and spend our money wisely. We really have to think about what's the infrastructure, what are the financial systems, what are the alignment of incentives between patients and doctors and hospitals. How do we get that all aligned to really think about providing health for our patient population? One of the ways in which we have to do that is to, on the provider side, is really think about being patient-centered. And I use that word purposely because it gets bandied around a lot. And frankly, I think the healthcare system, providers use it very easily. Oh yes, we're a patient-centered system. We think about patients all the time. Well, let me ask you a question, doctors. Why is it that if I have diabetes as a patient, I come in to see me as a primary care doctor, and then what do? I send you for a separate visit to see the nutritionist, a separate visit to see the endocrinologist, a separate visit to get your feet checked, a separate visit to see the kidney specialist. 6 visits later, you're getting all your care. Why is it that I don't have a center that is really sort of revolves around the patient, so you as the patient walk in and you see each of these people that you need for your diabetes care? We are still a very much doctor-centered system. As much as we say we're patient-centered, we really haven't even yet to scratch the surface. So that's one of the things that we need to do as a system, is to think about how do we become more patient-centered. And really, once we have to figure out how to engage patients more. So I think about Martha Coakley and your example of your husband's foot. Think about what would have been the cost savings there. It really wasn't, the price of the x-ray so much. It was really the fact that your husband got an x-ray and then a specialist visit and then something else and then some physical therapy, and then it basically got better on its own. If we could just figure out how to provide the care that we need, to be well integrated, to communicate to one another. How many of those providers talked to each other before they saw your husband to say, well, here's what I think, and here's what I tried, what's your thoughts? We don't do that enough. We don't communicate enough. And there's a lot of savings to be had if we just provide the care that's needed for patients, and we can eliminate the waste, extra care that's really not value added. One of the things that was brought up by somebody in the back there was about engaging patients. And how do you get patients engaged in participating in their care? And as a primary care doctor, I sympathize with the doctor back there who made this comment that it is difficult when patients are, quote, non-adherent or non-compliant. But the fact is that we really don't have the systems in place or the understanding to understand why it is that my patients don't lose weight when I tell them they should lose weight. Why do they, why do we have sausage and eat sausage for breakfast when we know we shouldn't be having sausage for breakfast every day? How many people had sausage? Who's with me? Yeah.
It's a sausage crowd.
That's right. It's good protein. There are ways, we are just beginning to scratch the surface on understanding what motivates patients. And there's a body of literature, research around shared decision-making. And it turns out that if you give men who are facing prostate cancer treatment, and you go to the doctor and the surgeon says, you need surgery. You go to the radiology person, they said, oh, you need radiation therapy. And you go to the oncologist, they said, oh, you need medical therapy. And so it's this whole paradigm of, who's looking out for the patient. Well, if you flip that around and you allow patients to interact with a video disc where they interact with patients who have been through surgery and they've been through medical treatment and they've been through radiotherapy. It turns out that, they take a watchful waiting approach. It turns out patients, when they get to choose after they really have sort of understood what other patients have felt like when they've been incontinent after prostate surgery, that maybe I don't want that surgery that I thought I needed. So we have to figure out how to engage patients and give them information so they can feel like they can participate in the decision making. Now, none of these things are easy, and there's a lot of work to be done, but it really sort of all revolves around helping us understand as providers how we become more patient-centered. On a practical level, what do healthcare systems need to do? Like the UMass Memorial Healthcare System, what do we need to do? Well, we have a medical center that's expensive. We do a lot of teaching there. There's a lot of research, and we need to be able to do high-cost care and do it well. And high-value, tertiary, complicated cases, we need to be able to do that well. But the gallbladders and appendix surgeries, probably should be done somewhere else, and we have to come to grips with that as a system and say we can't be all things to all people. As a primary care physician, I need to be able to have infrastructure to interact with my patients and keep them healthy in the community. I don't have a case manager who goes out to see patients in their homes who have diabetes or with congestive heart failure. We need to create that infrastructure, and that infrastructure requires some investment so that I can help keep my patients out of the hospital. And right now, that infrastructure doesn't exist. And specialists need to think about what they can do differently. So answer me this. So if I'm a man who lives in the northwest part of the United States and I have back pain, I'm about 3 to 4 times more likely to get back surgery up there if I live up there, just by virtue of living in that neighborhood, than I am in other parts of the country. And if you're a woman and you live in the southeast part of the United States, you're about 3 or 4 more times to have a hysterectomy than a woman in other parts of the country. Why is it? Those conditions are not different in those parts of the country. We have to, as specialists, examine the database, the evidence base for what we do, and make sure that we are providing the care that's needed, not the care that just happens to drive the economic engine. So, and then lastly, I would just close by, really this has a lot to do with collaboration and integration and working together, communicating, and finding out how do we align incentives. Employers, what can you do to make sure that your benefits design don't create an obstacle for the patient who needs a colonoscopy to screen for colon cancer, but says, doctor, I don't want to do that because it's going to cost me out of pocket. That benefit design needs to be rethought. We should have preventative care covered under benefits design. So the employer groups need to think about that. And we on the provider side need to think about what we can do to do a better job of keeping all of us and our families at home, at work, and healthy. Thank you.
Thank you, David. Let me follow up on the consumer engagement. The Attorney General mentioned the fact that we can't underestimate that. Senator Moore, we hear from employers all the time about, what can they do to encourage their employees to engage in their own health and well-being. And the question is there anything new in the payment reform legislation, that would provide employers with tools that they need in order to engage their employees, and does the new legislation support that type of engagement?
It does in a number of ways. As I think I mentioned earlier, the tax credit for a wellness program certainly is a benefit to the employer, provided it's one that they encourage their employees to utilize, and that there's an evaluation of its effectiveness with the outcomes that individuals have. There are several things going on that folks here in the room and across the Commonwealth have an opportunity to be part of the ongoing discussion as we continue to reform healthcare. And healthcare never gets reformed once. It's because of the population's getting older, the science is getting better, and a lot of things are going on that keep changing the dynamics and therefore require policy to adjust. But we're looking at, there's a study directed to the Department of Revenue to look at the potential for health savings accounts, flexible accounts that the portion of that the patient has to pay, or the worker or the employee has to pay, When we simply say, well, you can go to this place, but you're going to have a higher deductible, that is one way to try to control costs, but it also prevents, in many cases, the employee from even using their insurance because they don't have the money for the deductible. And so having a health savings account or health reimbursement account, one of those mechanisms, would give them the cash on hand. They get it by, they have a lower premium, but not as low as they'd be without it, because they take a little piece of that goes into that account and gives them then the access to health care that they need. There are about, at least I think about 7 or so or 8 studies that will suggest to you where we're going next with health reform. There's a study of diagnosis. There's something like 18% of medical diagnoses are wrong, and about 44% of diagnoses of cancer are wrong. And it's important that when someone has a serious diagnosis, that they have the opportunity to have that looked at by experts to make sure it's the right mechanism, so that they don't start a course of treatment that's not only not helpful because it's the wrong problem, but also, particularly in some diseases like cancer, where time can be a factor, you could be pushing somebody into a diagnosis that's also going to allow them to end up having them cost more or even not live longer because of it. We have certainly looking at the disparities that the Attorney General talked about. There are some cases where there might be a reason for a higher cost. If we're subsidizing the training of physicians, if we're subsidizing research through that cost, and there's a benefit to society to do both of those things, then we need to look at that might be a reason why we should have a little higher cost in some areas, or perhaps everywhere. And other things, simply market share doesn't seem to be particularly meritorious unless it also includes better outcomes as well. Certainly, we're looking at, we're expanding primary care. Someone raised the question earlier about the limited number of primary care physicians, and there's a couple of things going on there. We do have a program, it needs to have more funding in it, but a program that helps to reduce the debt that that a physician has coming out of medical school if they choose to go into primary care. But we also, you're expected to have a primary care provider, not necessarily a primary care physician. We've expanded the role of nurse practitioners and physician assistants to help with that. We are doing more with urgent care so that you don't have to go to the emergency room all the time for something that doesn't really require that high level and high expense type of treatment. The limited service clinics that are popping up, and CVS calls it Minute Clinic, but there are a variety of different ways of doing it, managed by a nurse practitioner that can take care of a lot of the prevention and wellness kinds of activities and the things that don't require surgery or something pretty sophisticated, that can help address the needs of the consumers. One of the things that UMass Memorial is doing is they've entered into a partnership with CVS to actually make sure that when you go into one of those Minute clinics, if you don't have a primary care provider, they will work with UMass Memorial to have that provider designated for you, help you choose one. If you do have one, they will provide a record electronically of treatment to the primary care physician, so they're still in the loop and can help coordinate your overall care. So I think there's a lot going on. There's a lot of opportunities for people to, both through the regulatory process as those get developed, to have comment and input, as well as through the additional research that's going on over the next year or so that will be the framework of our sixth healthcare reform bill in the last dozen years.
Thank you. I believe the Attorney General has to excuse herself. Thank you so much for being with us. Glen, so the individual mandate was a topic of conversation with the federal legislation. What do you see the future of that and the fair share rules as it relates to the legislation when it's fully enacted in 2014?
That's a great question. With respect to the individual mandate, as you probably know, Massachusetts has had an individual mandate requiring adults who can afford health insurance to have it, and that's been on the books since 2006. It was one of the central features of Chapter 58, a real important innovation that was really pioneered in Massachusetts. It's gone well, I think, by most accounts. It's helped bring more people into the ranks of the insured who could have afforded health insurance, and now they have the protection of health insurance, and we all benefit from a broader risk pool, which is great. National health reform, the Affordable Care Act, has an individual mandate too that takes effect in 2014. Many states, most states don't have an individual mandate. In fact, I don't think any other state has one. So those states across the nation are going to be wrestling with, for the first time, requiring some people who have voluntarily passed up health insurance who can afford it to enter the ranks of the insured. I hope and believe it can go as smoothly there as it has in Massachusetts. It takes very careful implementation, balancing the need to push people into the ranks of the insured who can afford it, but also distinguishing those who can't afford health insurance and making sure they have avenues to present their case, explain their circumstances, and take an approach with respect to them that doesn't penalize them, but really helps them when they can enter the ranks of the insured. The challenge in Massachusetts is less acclimating ourselves to an individual mandate. We've done that and done that well, but it's rather meshing state and federal individual mandates. They are similar, but not identical. And we will have to do some work to see how they fit together. I believe we can do that without adverse outcomes or big problems in Massachusetts. We'll need to mesh those rules to make sure that people aren't double penalized. We'll need to mesh those rules so that, for example, if people are filling out federal and state tax forms, it's a very easy, streamlined process, as there is today, for declaring whether or not you have health insurance, and if you didn't have it, what are the circumstances of that. That will be an important focus for the Health Connector in the Commonwealth over the next year. Again, the federal individual mandate takes effect in January of 2014. The federal law also has standards for employer responsibility. In other words, requirements focused on whether or not employers offer health insurance to their full-time employees. And if they don't, it imposes some penalties, particularly when those employees then proceed to show up in the health insurance exchange and purchase subsidized coverage. We, as you know, have on the books our own employer responsibility standards since 2006. It's known as the Fair Share test. There are some differences between the federal and state employer responsibility standards. One that immediately jumps out: the federal standard applies only to employers with 50 or more employees. The Fair Share test, though it varies in its applicability based on employer size, in general, it does apply to employers currently with 11 or more employees. I think that will go up to a threshold of about 25 in July of 2013. Okay, there we go. So we do need to take a look about how these two employer responsibility tests work together and consider if any refinements or changes are needed to create something that's, on the one hand, workable for employers, obviously an appropriate incentive or sort of rule to support employers continuing to offer insurance coverage to their employees, which most employers in Massachusetts do, without at the same time creating something that's administratively unworkable or unfairly burdensome to employers. The Health Connector will play an important role in that. The Health Connector recently received responsibility for policy setting with respect to the Fair Share test, inheriting that from the state's Division of Healthcare Finance and Policy. And we intend to think through these issues seriously, and the thing that we would value most is input from the employer community about their views, how they're working with Fair Share today, how they see the federal employer responsibility standard, their advice and counsel about how we should look at these two tests and any refinements we need to make. We would love to hear their views.
If I could just add to that, a couple of things that we are looking at during the coming year, because we're monitoring the federal health reform. Of course, we didn't want to go too far in case disaster hits and the wrong people get elected. And it gets...
Is that a political statement?
No, it's just a factual observation.
Or a preference.
But the issue of the individual mandate, a brilliant idea of the Heritage Foundation, a very conservative think tank, but actually a good idea because it has worked pretty well here and we have very high compliance. there are different penalties for not complying between the federal and state. I don't know that we've decided that that should be merged or that we should have only one penalty. Just as if you don't pay the right income tax, oftentimes that sets off both a problem both at the state and at the federal level, and there are two separate sets of penalties. So we're still looking at that as to what the right way to address that, and at least make it something that's consistent. But whether we would eliminate it is another matter. And then, and both Glen and John Hurst talked about the fair share contribution. That, by 2014, needs to involve companies of 50 or less would be exempt from the fair share contribution. We had started in Chapter 58 with basically 10 or less. So if you have 11 or more, you end up having to pay it. We moved it in the direction, I think, to begin to look at the federal plan, and probably we'll move it again in order to comply. The issue there is really a revenue issue. That there's money that comes in from that we need to that is paying for some of the subsidies that's involved in the overall program, and we need to figure out how are we going to replace that lost income if and when, and probably will, make that change. That's why even the improvement to the 25 doesn't take effect until July 1 of next year, so that we can have time to work that into the budget as a result to the loss of revenue even from that change. And at the same time, we'll be looking at finding the way to solve the bigger problem. And it's actually possible that we might, before July 1, move to the federal standard, provided we figured out the revenue side of things, to either, if it's not significant enough to ignore, but I think given that anything over about $10 is significant to the government these days, and probably to businesses as well. But it will be something that we're continuing to work on, and with both the connector and with groups like John's over what should be the right, how do we get there if that continues to be the federal standard. Now, if it gets repealed and the 50 no longer is a factor, we may end up just simply staying where we are, or looking at whether there's a better number or there's more evidence behind a particular size business rather than just picking an arbitrary number. But it is those factors are still things to be addressed in the coming term.
Thank you, John. Quickly, the co-ops. Are they a viable solution in the small group market, and what do you see their future being?
Well, I think they very much are. Right now there are 3 that are authorized. We're up and running. We'll see. We're looking with great anticipation of next year with the big renewal times of April 1. They're an additional important choice for small businesses and their employees. On top of the connector, on top of other options out there in the marketplace. The main thing that we're trying to do is to give small businesses the same type of opportunities that their big competitors have already in the marketplace, and we're trying to give them some ownership or bring them to the table. We want them to actually feel like they have a seat at the table with not only their own trade association type of people, their industry folks and their competitors, but also with their insurers and with their providers. I mean, that really hasn't been the case in the past. We're engaging them and getting them involved and having some ownership. And one of the main things that we hope to do through the whole cooperative experience is to make sure that we make them better educated consumers of healthcare. It matters where they go for what procedure, number one. And number two, where the rubber really meets the road is that we're, putting together some real viable wellness programs for them. Frankly, wellness is where it's at, and chronic condition prevention. I think everyone will acknowledge that. It's a challenge for small businesses, huge challenge. They don't have HR departments, and frankly, the way community rating is set up, it's almost like, why invest in a wellness program when, as you try to get your employees and their families healthier, and therefore your claims come down, your premium ought to come down in the future too, based upon your experience. That frankly is a lot of large employers, you may think they're doing it for being the right thing, but a lot of it is dollars and cents. They're doing it because there is going to be savings for both them and their employees investing in wellness. And that's something that we can do now through the cooperatives. You know, we can have an adjustment factor and save our employees and employers, small businesses, dollars in the future based upon their real experience, getting them to buy the right plans, to get healthier. You know, the senator mentioned limited service clinics, which he championed, and we expect, you know, where small businesses are all over the state, they're not consolidated in one location like a big business. You know, we expect to use those locations as important outlets for wellness screenings, biometric screenings, and the like. And you know, we want to find out where we need to improve their chronic conditions and prevent future costs. And they need to know that working together, you know, that is going to be positively not only impact their health in the future, but it's going to help them financially. You need to have financial incentives to get these small businesses and their employees to really engage in wellness. And you know, we've worked well with you know, Pat and his people. You know, they've come up with 5 great plans that we're offering now, and you know, and the other great option that we have, both through Pat's plans and now more recently October 1 through Blue Cross Blue Shield. You know, for the first time, small businesses don't have to just offer to their employees just one plan. You know, they can offer, in the case of Fallon, 5 plans, from a limited network to all the way to a PPO, and their employees can pick what's right for them, do a defined contribution. That hasn't been available for small businesses in the past, and through Blue Cross Blue Shield, they can choose amongst 3 plans. So, you know, instead of maybe buying up to what the employer wants, the Cadillac plan, maybe the 20-something just doesn't even have a primary care physician. They just want to comply with the law, right. and they want to have the lowest cost. And we're trying to be innovative and give them new choices and prevent costs in the future.
Great. Thank you. Dr. Fairchild, last question before we open it up to the audience. Big concerns around cost of care, quality of care, big concerns around getting to the price points relative to organizations, jobs, the loss of jobs and things. What are your biggest concerns?
Yeah, thanks, Pat. And I'll be quick because I want to make sure we have time for questions. You know, one of the things in terms of what keeps me awake at night and what do I worry about, is it quality of care? And I would say this is, you know, it's not my top concern because we are working on that. I will tell you that every doctor out there is doing their best in the system that they're working in. And the system isn't necessarily supporting the provision of the best care, but people are trying and we're measuring quality. So I think we're on the right track there. And in terms of the cost of care, obviously we do need to bring the cost of the care down. But in terms of, you know, pricing, I would say, you know, we probably should be being transparent. I mean, if a hospital in Boston wants to charge $15,000 for their PET scan, you know, let them do it and see who comes. But what we really need to do in terms of bend the cost curve is bring down the utilization of things that don't provide value. So taking the waste out of the system, that's where the benefit is. And what's you know, going to be the most important thing about eliminating waste, really, it's interesting. It's a lot about collaboration and integration and being able to communicate. So if my patient is being seen of mine in the emergency room and is having chest pain, and logically the emergency room is going to say, oh, that person needs to be admitted to the hospital for sure. But if they would call me, and this has happened, and I can say, well, that patient has had chest pain, you know, every day for the last 20, 30 days, and I'm working on it, send them to my office in the morning, and I'll see them, and I'll keep, you know, here's what I'm doing. Then the discussion is completely different. It's like, oh, okay, you know, that person's in a management program. The doctor will see them tomorrow. We don't need to admit them to the hospital. I mean, it's very simple, but those things happen every single day, and I can assure you. And so the whole idea that hospitals will talk to each other, that employers and insurers and doctors could actually partner together, as John was saying, around creating wellness programs that would work for the small employer. You know, that's where we have to get innovative and create integration and communication and collaboration where it doesn't exist right now. Frankly, the current system is very much just in sense silos. You know, let's do as many MRIs, let's do as many hospitalizations as we can. That's the way we make money. And so the system needs to change so that we now have the incentive to keep people healthy, to integrate with small employers, to work with our colleagues and friends at an insurance company that's thoughtful like Fallon Community Health Plan. You know, those are the things that are going to be exciting and will actually help us bend the cost curve as providers. So it's going to be exciting. And as you know, I think as much as there's a lot of work to do, I will say that doctors want to do the right thing for patients. That's really important to us. And we want the system to work for us and for patients as much as you want the system to work for you.
Thank you. Let's open it up for questions. Yes, ma'am.
Good morning. I represent Children's Friend, which is a behavioral health care provider. There's a strong mind-body connection. I think people will recognize that. As we move towards medical homes and global payments, those of us who are behavioral health providers are very concerned about the behavioral health needs of our clients, our patients, being left out, the care having to diminish because there's less money available for the behavioral health needs and not as much integration as there should be of the two. Could the panel comment on that and how we can make sure that doesn't happen?
Actually, the law itself calls for a very strong connection between behavioral health and physical health, and in addition to a commission being established to do more to figure out how we make sure we do it effectively. We know that one of the ways that whether you're an accountable care organization, become that, or a patient-centered medical home, or whatever the collaboration is that's going to be there, one of the ways that you can both save money and improve quality is to make sure you have the link with behavioral health, because it's probably not true 100%, but many of the folks who have chronic illness, and it's something like about 20% of the population, but about 70% of the cost of the health care is folks with chronic illness. They have a behavioral health issue that makes it more difficult for them to comply. The question came out earlier to the Attorney General from a representative of Harrington Hospital, one of the stellar healthcare providers in the region, happens to be in my district.
That's another commercial. We're going to start charging.
But it's the issue, the connection. You know, that if you have a behavioral health issue and you have also, whether it's diabetes or asthma or whatever the other issues might be that you have, your compliance with what's recommended treatment is not as good, and it might be irregular, might be not at all. And so the need for, if you're going to stay within the kind of the global budget of managing that patient, you better make sure that you've linked up with behavioral health to make sure that you can make sure they're going to comply with the treatment and therefore not end up in the emergency room periodically as they were, not require more extensive treatment than they otherwise need, than what's going on there. So I think there's several steps. The behavioral health side of things, mental health and substance abuse are very much integrated into the bill, and what we expect in the new payment models will be a key part of it.
Other question? Sir. Yes, sir.
Senator Moore, two things.
We do have a microphone here if you'd like.
Primary care physicians, I've lost 2 in the last 10 years who went into research because of lawsuits. Is there any initiatives to limit the malpractice lawsuits? Because primaries get roped in the legal system as the big pockets lawsuit, everybody involved. And they may not be responsible, but they're probably the ones that can least afford the huge premiums for malpractice insurance. Are there any plans to limit the amounts on these types of lawsuits?
There is major reform of medical malpractice. Limiting them to a particular cash amount is not on the table. Politically, it's not going to happen. Okay. The issue there is that whatever and the states that have done this are finding that they get pushed when some very dramatic case happens that costs more than the limit, and all of the people say, oh, we've got to change the law. Well, we don't want to get into that. What we have done is a couple of things that are involved. We give the provider, whoever that might be, it might be the doctor, it might be somebody else, who may be partly responsible. Oftentimes it's a system error, it's not just one individual. But wherever the fault seems to be, the ability to apologize to the patient without having that used against them later on in a lawsuit. And the opportunity to sit down and discuss and negotiate. There's a 6-month, roughly, waiting period before you entertain legal action. But you can bring your lawyer to this discussion, and in order to preserve your rights, to go forward with that discussion and find out what happened, what's going to be done to fix it, and what can be done to make sure it doesn't happen to somebody else. And that information oftentimes doesn't come out and sometimes doesn't even go to court. The insurance company, medical malpractice insurance company wants to settle if they think they might have a risk there. And it's usually a confidentiality agreement that's entered into by all parties. And so we don't learn from that error or whatever happened. This way, now we will be able to learn from what happened. We'll be able to improve the system overall to try to minimize. We'll alert everybody to whatever it was that went wrong, and also, or whether it requires different training at the medical school or somewhere else, or in continuing medical education. So we will have a system that has worked for the last 11 years in the state of Michigan in holding those costs down, because in a more effective system where we actually learn from it. So, and then there is also one of the commissions that we're looking at that will bring experts together is to look at if we have that system and it's working, we ought to see some savings from the tendency to practice defensive medicine, to do everything you can think of in case you do get sued later on. So I think there are a lot of steps being taken that protect the rights of the patient, but also recognize the importance of learning from that situation and helping the provider that sometimes feels pretty guilty too, to help them get through it so that they can work together with the system to improve it.
Second question, it's not really a question, it's a comment. Martha Coakley mentioned that we need a paradigm shift. The Ozzie and Harriet mentality that a lot of us older people have is usually passed on to our children in the home. I'm thinking that there should be some education, maybe in the high schools. I don't know what the cost of this would be, to change that thinking so that when they get older and need more care, they'll question things, they'll look at videos and options and be aware of the cost involved and what their best options are. I think if you want to make a paradigm shift that's going to last a long, long time, it should start with the youth, and that's just a comment from me.
Let me make an observation, because I think you hit on a key point. We're in the midst of what I would call an incredible cultural shift, right? From where we were 30 years ago to where we are today, to where we hope to be somewhere down the road. And so education, information, is going to be a critical part of how we change this culture and how we move forward to a better place, to more predictable cost, to better quality, better outcomes, and better decisions on the part of everybody within the providing of care. So I think that, and it's not going to happen overnight. We didn't get to where we are overnight, and we're not going to get out of it overnight. It's going to take time. And the other thing is that there's just not all one solution. It's not one size fits all. What plays in Poughkeepsie doesn't necessarily play in Holden or Shrewsbury or Worcester. And so we need to work our way through a lot of these things, and we're going to stub our toes. But I do believe that the journey has begun. And I do believe that the professionals within this room and the legislators are committed to finding our way forward to more sustainable, quality-based, affordable health care. So, young lady right there is going to dislocate her shoulder. Are there any Republicans here today? Oh, there you go. If I might, Senator, you have to leave. Senator Moore is going to have to leave us right now. It's actually 10:15. You want to?
Got a question.
Well,
do you have one for Senator Moore?
Bless you, sir.
Are you in his district?
Where are you from? All right.
If not, the hell with you.
Thank you, gentlemen, for all of you being here today. My question has to do with the what you see as the future of mobile health solutions. Doctor, at UMass Memorial, are you talking about how you're going to integrate various telehealth kinds of options to your patients? You talk about the clinics. Maybe that would be a way to tie the medical staff to the people who are managing those clinics. And the biggest question, of course, is how do you calculate fee for service in that circumstance?
Right, well, before the doctor gets into that, because he can give you, well, you're not going to send her a bill for it, are you? There are a couple of important things. Yesterday, I was at Mass General Hospital, where the governor transmitted his electronic health record to providers at Bay State Medical Center in Springfield in a matter of seconds. And we're way ahead of the rest of the country in electronic health records and the information highway. In that regards, we've already had about $35 million in federal money. The system is designed that has been developed and is being rolled out. Is designed to work with a number of different vendors. So it doesn't matter to some degree what system you have, electronic record system you have. It will work with it. The providers, the fee is going to be $5 a month, so $60 a year. So most providers should be able to afford that. If they're not very good business people, and they need to talk to John about getting into another business. But it's developing, and we've got in both the health bill we just did and in earlier iterations of back in the 2008 bill, we provided funding for it. There is federal money, and what we wanted to make sure of is that the small providers, small practices, for instance, the skilled nursing facilities and others, that they have some opportunity for grants to help with their costs too, because the federal money hasn't extended down to all levels. So we're really working at that, and we'll probably continue to look for ways to be helpful with that initial, especially with the initial cost of the software, the technology, the training, things that are involved in it. But it will be possible if one of the doctor's patients is off in, well, with the Attorney General up in Maine or someplace, and they have an emergency, it'll be possible to get that record. So they don't have to go through a lot of expensive tests that aren't going to be productive and waste a lot of time, as well as money in the process. But I'll let the doctor talk about how he's going to do it too.
I think it's a great question, and one of the things that I would say is by being uncoupled from fee-for-service in the new paradigm, the new environment of healthcare reimbursement, will give us the opportunity to make those things work. Frankly, we've been talking about doing those things. We would love to do those things. Right now, it's been difficult to find a way to get them paid for. But the opportunity to, as the Senator said, to communicate with hospitals, to communicate with a patient, I would love to set up with some of John's companies to be able to have telehealth so that a patient who's in the employer building could communicate with me, and we could have a doctor visit right then and there. The patient stays in place, is present, not absent, because of the doctor appointment. And from my point of view, it's quick and easy, and we just have to have a mechanism to make that financially worth our while. So I think it's a great question. I'm looking forward to we're making it work.
Thank you. Yes, sir. Oh, no. Just wait.
So
that's why I'm here, right here. Illegal procedure?
We'll take the penalty.
All right. There you go.
You guys have all
second and 10. Go ahead.
You've all touched upon wellness, and so my question to you is, how do you define wellness, and what are the vehicles for promoting wellness that you see that are going to be most successful for patients, clients, businesses, so forth? And then what are the opportunities for small local wellness providers to access you guys in respect to being able to provide, promote our services through your organizations, but work as a collaboration to do so? And then what would your expectations be for wellness providers in order to have the privilege to do so?
Well, let me just give my 2 cents worth in. It's an interesting thing, and going to small businesses, because frankly, in our cooperative, we actually have rules, participation rules on wellness. That's one of the things that's going to make this work. You know, each small business has to have at least 50% of their employees and family members participating in wellness. And they said, you know, they're coming back to us or through their broker and saying, what does that mean? I have to go to the gym. You know, what does that mean? We're going to be targeting how we can best deal with, frankly, chronic conditions. You know, it isn't, for some people, it's yeah, you know, for some people would like to see them go to the gym. Other people, we're going to be doing, we're going to have mandated biometric screenings. We want to find out what is, you know, where we can best invest our time, our money, and our efforts to make the collective group healthier. And you know, and it's a lot of education. It's a challenge for little guys. I think the telecommunity, you know, medicine is a great opportunity that we want to look at as well, and you know, local providers, you know, anyone we can bring in to particularly go to these folks that, you know, are not in one big, you know, location of employment. It's you know, it's the next big challenge, because everyone knows that wellness is where it's at. I mean, we got to avoid costs, but it's going to take a lot of education and a lot of efforts to outreach, particularly to employees of small businesses.
We'd like to likewise love to know what local wellness providers are doing, the types of solutions they offer, and see if there are any opportunities for synergies between our efforts to promote wellness and the things they do. So we'd love to hear more.
Yes, sir. See how I went right back there?
You keep referring to the employer. Yeah. The employer. Was it in the 40s or the 50s that it started to refer to the employers became responsible for their employees' health care? I started a company 20 years ago with working for Glen, so I had big mother Gillette thing, you know, you get a job there when you're in your 20s. You have health care there. All of a sudden, I decided I want to start my own business 20 years ago. I didn't have a clue. So I become the lord of my employees' health care decisions, because I decided to provide a lot of Boston at the time. My employees didn't have a choice. I decided on the brand that they should have. It should be my responsibility. I'm a marketer. I'm not an HR person. I'm not capable of making the right decision really for my employees. And what I have found, I think the connector is a great idea. It's phenomenal. What we're discussing today is invaluable to me. But belonging to a group of other marketing firms that are retailers, so we would never think about doing it in our organization. Although I think it's phenomenal. I try to sell most of them, so enjoy. But the fact of the matter is, most of us have no awareness and understanding of the connector but if we want to go from there. So the first part of the question was, when did employers look at pensions say, when did this start?
It was after the war, actually, in the 50s when employers began to become more involved. It became a part of compensation.
So it became almost a mandate that employers, I must have heard employers referred to 50 times this morning. What a daunting responsibility for a mid-sized business. Not the money. The decision is to Ludovic, Fallon, Hurst, Harvard Pilgrim, Blue Cross, tiered plans, and then we just tell our employees, this is your one and only choice.
Well, I make it easy. It's Fallon is the choice. So we'll do that. We'll do that one right off the bat. You know. Right.
And the two of us have to decide between people.
Yeah.
So they're mandated.
So I would just say, first and foremost, there's a gentleman sitting over there, and his name is David Kerrigan, and he's the Director of Business Development for the Health Connector. He's one table away from you, and I'm quite confident he's going to be grabbing you after this breakfast is over and telling you everything the Health Connector can do to help small business owners.
As long as it's Fallon.
It's on our shelf with more products starting in January. I already covered that. I also, the Health Connector is really at the beginning of its life cycle and helping being a tool for small employers to help them and also help their employees fashion coverage solutions that meet their needs. We're going to do a lot more work to get the word out about the Health Connector, and I think you'll see that particularly in conjunction with our efforts around 2014 to become a health insurance exchange that's not only impactful in the market but also compliant with the Affordable Care Act. I do think the world is changing. That doesn't mean that employers are altogether getting out of the business of having something to do with how employees get their health care, but I think the world is changing definitely towards more employee involvement in making health insurance and healthcare decisions. The conversation about wellness is very much about that, recognizing that premiums could very well be affected in a positive way if we can get employees engaged in their health and wellness and prevent sickness before it happens. And I think that coverage models are evolving. We piloted and will return to coverage models where employees themselves have a little bit more of a say in what carrier they want to choose, including Fallon. So, you know, the world is changing, and the connector, I think, will be very much part of the solution for employers and employees.
I'll continue the theme. I think that the other piece of it is that there is presently debate within the industry. There are insurance brokers who are very good at providing value, helping you ferret through solutions and choices and other things like that, become an extension of your organization and do a phenomenal job. The other piece that's happening, and it's really grassroots, but we're beginning to see more of a defined contribution on the part of employers, where and allowing their employees to go into the market to purchase their own health insurance, and that is going to continue to evolve. But the connector, insurance brokers, there are a lot of opportunities to help you make those decisions and to help educate you in terms of what the options and opportunities are for you in your business. So, good question.
Let me just add, too, I'd be remiss if I didn't mention there is another cooperative out there up and running right now outside. We're just the retail sector. We're trying to stay relatively homogenous, but the collaboration of the local chambers of commerce is also up and running as well, which takes all types of employers. It's something else to look at.
Yes, sir.
I just wonder if, I think this would have been a great question for Senator Moore, but I have a question in regard to the concept of an ACO. I think I'm involved with a physical therapy practice that has a wellness facility attached to it locally, and we're a small private company, and we're very concerned about the, I guess you could say, an enigma of what an ACO is. There's been a lot of talk about it, that they'll be forming. There's been a lot of talk about that this is coming, but not really a lot of the details about what it will look like and how it will affect a small local company like ours. So I wonder if you all have the, can talk about that, and what can a small business in this area do to learn more about the ACO, and then how will the ACO affect the employer as well as the employee too?
I mean, I can take a stab at that. So the ACO is an accountable care organization, and it's a federally mandated program where hospitals or medical groups can form an accountable care organization and have a population of patients that they become accountable for. And so they will get paid to take care of this population of patients. And so if UMass is thinking about doing this, we're not one, but if we were one, we would be accountable for all of the patients who had a primary care doctor that were in the managed care network that we have. So all the PCPs that are in the ACO with us. And so if you were a patient in that of one of those doctors, you'd be in the ACO, and we would be trying to manage your health care. And so it's really thinking about what I was saying right at the beginning. How do we keep that population of patients healthy? And it really is about, to do that, it's really about integrating across the entire continuum of care to make sure that we are managing that care every step of the way. I mean, I say in lectures to doctors, I say, you know, we used to think about people getting discharged from the hospital or discharged from the rehab center. And I say, there's no more, you're not using that word anymore. There's no such thing as a discharge anymore. You get transitioned from the hospital, and somebody else is going to pick up the ball, and somebody else is going to be caring for that patient. And so your company will be part of that continuum of care. And so I think from the company's point of view is to think about how do you create relationships and integrate and collaborate with the doctors, the people who send you patients, and what can you do for us similarly. So we want to make sure that our patients are well cared for, that they don't bounce back into the hospital and have infections after surgeries and things like that. So we're trying to make sure that we're managing the care of our patients wherever they are throughout that continuum of care. So it's, I think, you know, in the end, the winner in all this, as much as there's going to be a lot of competition between different accountable care organizations. I mean, St. Vincent's may set up an accountable care organization, and UMass may set up an accountable care organization. We may be competing, but at the same time, the winner in all this competition is really going to be the patients, because I do think that this system will provide more thoughtful, more continuous, and more supportive, high-quality care for patients. So in the end, I think it's a winner.
Yes, ma'am.
Healthcare reform is full of alphabet soup. We're hearing all kinds of different acronyms being used, like ACOs. Another one I've heard quite frequently is patient-centered medical homes. What are they, first of all, and how does that fit into the present construct in the provider-based system, and what impact will it have on the existing structure as we know it today?
Yeah, so it's a great question. So the patient-centered medical home is another one of these concepts of how to put the patient in the center of care and really focus on that care. And so really what it is a group of providers revolving around a population of patients to try to provide patient-centered care. And so it's often involving primary care doctors, but then also other ancillary providers like nutritionists and physical therapists and mental health providers are often embedded in these patient-centered medical homes. So it's that idea of one-stop shopping, that you could come in and have a series of issues and we would have a provider there that would be, could help take care of that. You know, interestingly, I think the jury's still out in terms of whether or not the patient-centered medical home is the solution or not, but the concept is the same as that we've been talking about: integrated care, putting the patients at the center, and it's one of a series of experiments, frankly, to, you know, try to do a better job. It's, you know, none of this is easy, I can tell you, and so we have patient-centered medical homes that are working and they're doing a nice job. Is it a home run? You know, care is much better, cheaper, patients are, you know, fabulously healthy and happy. You know, not yet, but it's another in a series of experiments putting the patients in the middle.
So it's more of a virtual entity versus bricks and mortar kind of entity like we know of the traditional healthcare delivery system now.
That's right, it's more of a virtual setup. So it could look and feel just the same way as the practice was the week before, but now they're organized in a different way and different providers there to be more patient-centered. That's correct.
Peter. One last question. Yes, sir.
This has been really educational. I've really learned a lot. Thank you very much. And listening to all the comments that have been given here today, I'm thinking to myself, are we all of us, trying to baffle ourselves by trying to please everybody, every constituency, every provider, everyone, all the time, in every way, and as a result, we're pleasing nobody? Is there an answer to that? The objective here should be to do no harm.
Just real quick, you know,
Who the hell wants that?
I don't. We could have a whole separate breakfast on that.
Answer?
But let me just say, I think in the future we've got to, you know, hey, this is extremely complex. It's historically been very much influenced by the providers and others that deal with this every day. And what we need to do is more education and more empowerment of the consumers. Ultimately, the consumer needs to have more decision-making and more power, and they need to be put first as opposed to putting the provider first. And, you know, ultimately, that's what's going to make all this affordable and politically acceptable.
I think David's point just a minute ago relative to the fact that that the more things that are going on, ultimately prices begin to come down, quality begins to improve. There are new delivery systems that are created, and the byproduct, I think, of all of those, I think what they've got to keep in the forefront of their mind when they enter into these accountable care organizations or patient-centered medical homes or anything of that nature, is that the objective is quality-based, affordable health care that is sustainable and predictable for the small business owner and the large business owner on a go-forward basis. And I believe that's the challenge that we've all accepted to make it better. And it looks like herding cats right now, and it's a little bit of that. But at the end of the day, I think, and change is not easy and you're trying to, you're changing a culture. And anybody who's ever tried to change a culture in an organization knows how difficult that is. And we're trying to change the culture of an industry that represents 18% of gross domestic product. Significant. So, but great question, thank you. And I'd like to thank the panel, great job.
Sure. Pat, before you take off, we want to, I tell you, we all suffered through the replacement referees. That was a real referee at the mic here. Thank you for a tremendous job moderating, and thank you to our panel for a fantastic job. As a wrap-up, I just want to say to Dr. Fairchild, when I was in the back of the room handing out the microphones, I picked up the little lids of all those trays while they were out there and saw the fruit tray picked through, but lots of sausage and lots of bacon still sitting there. So I think, the message may be getting across. Anyways, to our presenting sponsors, Fallon Community Health Plan, to our media partner, WTAG, and to special thanks to Curry Printing, Elevation Exhibits, Mark Serra Productions, who shot a video of this, and we will send a link if we have our email address. It'll be posted on the WBJ site and sort of chapterized, so you don't have to watch a 2-hour comment. If you want to forward that to someone else, we'll have that content available. And also Revelation Productions and Ron Belay Photography. Thank all of them and all of you for coming. We're very pleased. This was both entertaining and informative, which is always the right mix. So thanks again for coming, and enjoy the rest of your morning.